Now, trochanteric bursitis or recalcitrant trochanteric bursitis, to me, I think is equivalent to the pre-arthroscopy era biceps tendonitis in the shoulder. I don't know if there's anybody on this meeting that was familiar with the pre-arthroscopy era of biceps tendonitis, but before the arthroscope, all the anterior shoulder pain, you got biceps tendonitis. But with the arthroscope, we realize that isolated biceps tendonitis is infrequent. We see slap tears, undersurface rotator cuff tears, subscap, a lot of things, but usually not just an isolated biceps tendonitis. And that led to the term greater trochanteric pain syndrome, which, although less specific, is probably more accurate for describing the constellation of things that can present as laterally based hip pain. With differential palpation, if you know the anatomy, you can identify various structures. Differential strength testing, with the knee flexed, you're isolating the gluteus medius and abduction. With an extension, you're recruiting the IT band, and if you flex the hip, you're bringing the gluteus maximus into play. Ultrasound and ultrasound-guided injections can have diagnostic and therapeutic value. Now, I used to run the other way from laterally based hip pain because I thought they were old people, they're miserable, and they're hard to sort out. But I figured out only 2 of those 3 things are true. They are an elderly population. They are severely disabled, but they're not that difficult to sort out. This is the first case I ever did, sort of, for the shoulder surgeons. If it's just kind of like a rotator cuff going sideways, we used double row fixation, 3 transversely oriented proximal row and knotless distal row, and it worked. And then subsequently over time, sort of begrudgingly, I collected a few of these cases, and with our 2-year follow-up, we found out that with the abductor repairs, when we compared them to our previous published data on FAI, we found that these patients were 20 years older than FAI patients. They were pretty much all females. Their preoperative baseline modified Harris hip scores were 20 points worse than our FAI patients, but their amount of improvement was double that what we saw with the FAI. This really dispels a couple of myths about hip arthroscopy. Number one, that older patients don't do well with hip arthroscopy. This is one of the most successful populations that we see. And also that low preoperative baseline scores are an indicator of poor outcomes. But these patients are severely disabled and can do exceptionally well.